Patient comes in with shoulder pain with overhead movements. They have a positive NIRS test. They have a positive Hawkins-Kennedy test. They have pain with manual muscle testing of the infraspinatus, supraspinatus, and teres minor. So, hurts to do this, hurts to do this, hurts with overhand movement. What's the diagnosis? What would people call it? You guys know. Impingement. It's an impingement. Somebody has a subacromial impingement, let's say. Great. So now you have your diagnosis, and when I was a clinician at the school, someone would come to you, or a tutor at the school, someone would come to me and say, you know, Dr. Spina, I have a patient here, they have a positive NIR impingement, they have a positive Hawkins-Kennedy. I think the diagnosis is subacromial impingement. You feel all good about yourself, you feel like you nailed the diagnosis, and then I say, great, what are you going to do for them? So what's the answer? What do you do for subacromial impingement? Examples? Don't be shy. Somebody give me an example. What do you guys do in clinic? What do you do for a shoulder? How do you treat some shoulder injury? What would you do? What would you do?
Or just started clinic on Monday, but I think I do strengthening exercises.
Okay, strengthening exercises, that's one modality. There's ultrasound, maybe. Some people like to lather people up with ultrasound. Maybe we'll do some laser, maybe we'll do some active release. Great technique. Some people might do trigenics, some people might do Graston. So people would give you a list as what they do for subacromial impingement. The problem is, in my opinion, subacromial impingement is not really a diagnosis, it's more of a category of diagnosis. Subacromial impingement can be anything from supraspinatus insertional tendinopathy, subacromial bursitis, or subscapular bursitis. It could be an internal impingement or posterior superior glenohumeral joint impingement. It could be a bicipital impingement, so a biceps tendinopathy. It could be a biceps tenosynovitis. It could be a lot of different things. But if we went with the let's just pick randomly any kind of type of treatment and apply it, you would not get the specificity that you need in order to battle the problem. So for example, if somebody had an insertional tendinopathy of their supraspinatus muscle, what would we do for it then? What would the research say would be a good idea then? We would be very aggressive with it. We might do a lot of ART. People might do some cross friction. People might do some Graston. People might try to really irritate the tendon to get some blood or to get some healing occurring. And then they might put them on an eccentric training program. Eccentric training program, of course, will help to redevelop new proteins. It'll help to kill the extra blood supply that's infused into the tendon, which is causing the pain. It would do a lot of great things for tendinopathy. But what if that subacromial impingement represented a bursitis? Now what would happen if I took the Graston tool and started hacking away at the subacromial space? It would get worse. It would get a lot worse. And the reason being is because we never really had a specific musculoskeletal diagnosis to guide our treatment. We just took a general area that had an ouchie, and now we're applying things randomly. So we're going to poke and prod in hopes that something will get better. So the only true way to differentiate the symptomatic tissue, especially in this case, lies in the practitioner's ability to palpate the boo-boo. You need to palpate the boo-boo. You need to find exactly what tissue is inflamed, or adhesed, or torn, or whatever. If you have the exact diagnosis, then you can develop a treatment plan which is going to exactly focus on the specific findings of that person's complaint. So, the accuracy of the derived diagnosis is dependent on the practitioner's ability to clearly distinguish between anatomical structure and between normal versus abnormal tissue. The effectiveness of the treatment protocol that follows that diagnosis is completely relies on the outcome of number one. So if you have a specific diagnosis, if you have a very good understanding as to the pathological problem that's occurring, and you have a very specific idea as to which structure is injured, then the treatment plan that you develop or the tools that you choose in order to combat those symptoms are going to be more specific, and therefore you are going to end up with better results. Which is our motto for the weekend here, is that your the specificity of the diagnosis will equal the specificity of treatment, which equals the specificity of results. So the better your diagnosis, the more clear and understandable and specific your diagnosis, the better results you're going to have for that patient.